Okay, so good afternoon, everybody. Thank you for joining our today's webinar, which is entitled Diagnostic Algorithm for Childhood Onset Chorea, and it will be presented by Darío Ortigoza-Escobar from the San Juan de Dios Hospital in Barcelona. My name is Anja Hermans, and I work at the Institute for Medical Genetics at the University Hospital Tübingen in Germany. In Tübingen, we are coordinating the European Reference Network for Rare Neurological Diseases, and I'm there responsible for the training activities. So together with another reference network, the one for neuromuscular diseases and the European Academy of Neurology, we have started this joint educational initiative, and this webinar is part of it. Just some words on the European reference networks. There are 24 ERNs in Europe. They were established in 2017 by the European Commission, and they are groupings of expert centers across Europe. So those centers, healthcare providers have a specific expertise on specific disease field, and our network covers the neurological diseases. The goal of these networks is to better connect those healthcare providers to facilitate the exchange of knowledge and experiences, and so to say, to intensify their collaboration. So what we are doing today is also sharing knowledge and also sharing experiences is possible also through the clinical patient management system, through the CPMS, for example. So all of those steps or procedures are done in order eventually to help the patients to improve the quality of care, to deliver more timely diagnosis, etc. So we have 32 at the moment, full members in the dark blue countries and 10 affiliated partners in the light blue countries. But we will be soon expanding with approximately other 30 institutions coming in 2021. Our network is covering these 6 disease groups that are listed here. So just some general information about these webinars. We are recording this webinar, so you can view it afterwards from our website. We will have 40 to 45 minutes presentation, and at the end we will have questions and answers session. And you may also be interested to look up in the Disease Knowledge Hub on our website, so you can just choose the disease in which you are interested in. At the end of this webinar, your browser will open a satisfaction survey, so please just take 2 to 3 minutes to fill it out and to tell us about your impression and to propose topics for new webinars. We will be very grateful to receive your feedback. Okay, so besides the clinicians that are in our network, we have also patient representatives. In this case, for this disease group, it is Astrid Arnesen. She's also president of the European Huntington Association. So I would like to show you a short video in order to show you also her perspective the perspective of the patients or patient representatives. I hope you can hear it.
My name is Astrid Arnesen, and I am one of 6 patient representatives in the Rare Neurological Disease Networks, and I'm very happy for your attendance at this webinar. One of the main objectives of the network is to share knowledge and bring clinicians together to discuss best practice. As patient representatives, we have very high aspirations for the network, as we want every rare disease patient to have access to expertise when needed. And webinars like this, and not the least a network of colleagues, we strongly encourage you to make use of this shared knowledge among colleagues when faced with the unknown. Because, let's face it, nobody, no matter how well trained or experienced you are, can know everything. And patients recognize that. We don't expect you to know everything firsthand. But faced with the unknown, we expect you to say, I will consult somebody else who may know more about this. Because as a collective, knowledge gets multiplied and even better further developed. This is, in our opinion, one of the main objectives of the European reference networks. I wish you a very good webinar and hope you will stay curious.
Okay. Thank you, Astrid. And again, I will come back to the presentation, or better said, I would like to introduce our today's speaker, Juan Darío Ortigoza-Escobar. His current position is a consultant child neurologist and head of the movement disorders unit at the Hospital San Juan de Dios in Barcelona. And he's there since 2017. He has obtained his training in pediatry in Paraguay and in Barcelona, and his specialist training in child neurology in Barcelona. His research is focusing on movement disorders with childhood onset, and he has special interest in choreas and thiamine responsive disorders, as well as deep brain stimulation. So, Dario, thank you very much for accepting our invitation. Thank you for investing this time, because we are very aware that this is not done just by the way. There is a huge time investment and resources in it. So thank you again, and we can start with the presentation.
Thank you very much for the introduction, Sandhya. Can you see the yes. presentation? Yes. In this presentation, today we will define chorea, atetosis, and balism. We will talk about the pathophysiology and the physical examination of a patient with chorea. As a main point, we will comment on a diagnostic algorithm where we will discuss acquired and genetic causes, including inborn error of metabolism, epileptic encephalopathy, and other genetic causes. And we are going to hint some treatment. By the end of this webinar, you will be able to discuss the clinical feature of chorea, identify the commonest causes of acquired and genetic chorea, recognize the sign as a part of inborn error of metabolism and epileptic encephalopathy, and outline the genetic approximation in a child with suspected genetic chorea. Chorea, by the definition of the Childhood Movement Disorder Task Force by Sanger and all of the year 2010, is defined as involuntary, continual, abrupt, rapid, brief, irregular movement that flows randomly from one body part to another. Movement appear random and can vary in time, duration, direction, and anatomic location. Also, chorea can be partially suppressed. Chorea can involve any body part, although it's more common in face, tongue, and extremity. Some children can camouflage the chorea by incorporating the movement into semi-purposeful activities. This is known as parakinesia. Children and parents describe chorea as clumsiness or motor impersistence, or can describe the effect of chorea in, for example, in gait or manual activity. For example, they say the children have a clumsy gait or the children have frequent falling of objects from their hands. There are two terms related to chorea. There are the vallism and the athetosis. Vallism consists of large amplitude movement of the limbs and mainly affects proximal joints such as shoulder or hip. On the contrary, athetosis involves the distal part of the extremity and consists of a slow, continuous, involuntary movement, for example, of the fingers. Chorea, athetosis, and vallism may overlap in the same patient and cannot be differentiated as mutually exclusive phenomena. To understand the pathophysiology of chorea, we have to know that chorea can be originated in any part of the brain, in the cerebral cortex, in the basal ganglia, in the cerebellum, and the thalamus. Here in the figure, you can see the excitatory pathway marked in red and the inhibitory pathway marked in blue. In chorea, there is a loss of inhibitory action of the putamen over the GPI and also a loss of inhibitory action of GPI over the thalamus. And on the contrary, there is an increase of the excitatory of the excitation from the GPA to the subthalamic nucleus and over the GPI. There are some very useful clinical signs that allow us to say that a patient has chorea. The first of those signs is the spooning sign. In this case, we see a patient with glutaric aciduria. On the left, you can see the MRI here. It has hyperintensity in the posterior part of the putamen. For the spooning sign, we ask the child to extend both arms straight forward horizontally from the shoulder with the hands pronated and the fingers spread wide. In this case, the children will tend to hyperextend the metacarpophalangeal joint. This is the spooning sign, as you can see here. This is dystonic, it's like a dystonic posturing of the hand. A spooning sign also tends to induce more chorea in proximal and distal arm muscle. And if we add an additional task such as protruding the tongue, the chorea will get worse. In the same child, we observe the touchdown sign. For this sign, we ask the child to extend both arms vertically from the shoulder with the palm facing each other. This will induce chorea and will result in the pronation and the elbow flexion, as you can see here in the video. For the next sign, we observe another child with glutaric aciduria. In this case, the MRI to the left of his acute decompensation shows a hyperintensity of the putamen and the GPI. For the darting tongue sign, we ask the child to stick out his tongue. He will attempt to cooperate, but the tongue protrusion cannot be maintained. That's what we call darting tongue. We don't have a video for the last sign, which is the milkmaid grip. For this sign, we offer the child to squeeze our index and middle finger together of both hands. The child will attempt to squeeze both hands, but he wouldn't or he couldn't persist in squeezing. Each time the grip release, he will try to squeeze again. As this happens repeatedly, this will resemble as the child is milking our finger. There are two very important clues from the medical history that can help us to diagnose the chorea. The first of them is the duration. The chorea can be continuous or paroxysmal. Paroxysmal chorea often is associated with dystonia and is known as paroxysmal dyskinesia. Paroxysmal dyskinesia can be caused by all these genes in the blue box on the left. In the video, we see the girl with a paroxysmal dyskinesia due to PRRT2 mutation. When she finished to running down the hall, we can observe this generalized choreodystonic movement that involve both upper and lower limbs. In this case, this paroxysmal dyskinesia that we see right now lasts less than 10 seconds. And that's characteristic for a PRRT2 mutation. In the next video, we will see another girl with a paroxysmal movement disorder. In this case, this child is affected by a GLUT1 transporter deficiency. She presented this paroxysmal dyskinesia that lasts up to 40 minutes. As you can see in the video, she has difficulties to stand up, and she will present frequent falls, as you can see in the video. But between the episodes, this child is completely normal. There is a past webinar on paroxysmal disorders by Giovanna Sorsi that can be accessed at the ERN webpage. And in her presentation, she talked more in details about these genes and paroxysmal disorders. Now it's time for a question.
Yes, I will show the poll. Now you should be able to see the question and vote.
This is a question about our next diagnostic look for chorea, which is the distribution. As we mentioned, chorea can be generalized or it can be presented as hemicorea.
Okay, 10 seconds to go. You have still the possibility to give your vote. Okay, so not everybody has responded. I see here only 58% of the participants, but still I will show the results.
Very interesting. People mentioned that all of the above causes hemicorea in a 42%, and that's the correct answer, as we will see here. Are you still seeing my desktop? Yes.
Yes, we see it, but you could start the video from the beginning, Dario, because it.
Okay.
Yes.
Through the literature review, we can confirm that hemicorea is always due to an acquired cause, except for a Wilson disease that appear here, which is a genetic cause. In this video, for example, we see a girl with side hand hemicorea. I will put it from the beginning. You can see here that she has a right hemicorea. And this was started after a pharyngitis. The second part of the video, you will see as she was treated with carbamazepine, and she has very good results. Now we will comment on the diagnostic algorithm on childhood onset chorea. This algorithm was developed for the ERN chorea and Huntington disease group and is in preparation to be published. As the first step of this algorithm, we have to diagnose the chorea according to the sign we have discussed previously. based on the medical history and the physical examination, but also on biochemical study or MRI, we will decide is if the onset is acute or happen in a child older than 5 years of age, we will think of acquired chorea. If, on the contrary, the chorea happened insidiously or in a child younger than 5 years of age, we will think of genetic chorea. We will comment on these aspects through the presentation because there are exceptions in both groups. That is, there are causes that happen in children younger than 5 years old that are acquired, for example, kernicterus, and there are also genetic causes that can present acutely, for example, glutaric aciduria or any other metabolic disease when it's decompensated. In both groups, MRI will be essential to guide the clinical picture. We will see that if we classify the patient as suggestive for genetic chorea, we will ask for targeted sequences of the most common genes, and also for the study of deletion or duplication or repeat expansion panels. Unfortunately, it is likely that despite all our diagnostic effort, we will fail to diagnose some patients, and we will call this group of patients like unsolved chorea group. We also have to think about treatable disorders along the diagnosis process. Now we will comment on acquired chorea first and then on genetic chorea. In this algorithm, the acquired chorea will be classified into 5 subgroups. These groups will be structural basal-ganglia lesions, parainfectious and autoimmune chorea, infectious chorea, metabolic or toxic chorea, and drug-induced chorea. Like other algorithms, the initial step will be to find out if the patient takes any medication. That's for the drug-induced chorea. As a second step, we will find out about fever or any other symptom related to infection, such as rash, travel abroad, or any other sign of infection. For the third step, we will require some laboratory testing. In this testing, we could include not only metabolic or toxic causes, but also parainfectious or autoimmune causes. And finally, the MRI will be very useful to assess not only a structural basal ganglia lesion, but also can give us some VIP clues on the other groups. As you can see here, in this gray box, there is the recommended laboratory testing to rule out acquired causes. Also, here we include an electrocardiogram and a cardiac evaluation. That is because side and hand chorea is very frequent. Now we will see some practical examples of the most important groups. One of the most common causes of acquired chorea is dyskinetic cerebral palsy. Here in the video, you can see that this child has not only chorea, but also dystonia. That's a frequent association in dyskinetic cerebral palsy. Also, MRI is very useful in these cases because a patient has lesions in putamen, thalamus, or they can have periventricular leukomalacia. And dyskinetic cerebral palsy accounts for about 2 to 5% of all cerebral palsy cases. Another less common cause of acquired chorea is kernicterus. Here you can see that the patient also has not only chorea, but also dystonic posturing. In the MRI, there is a hyperintensity of the globus pallidus. And what is very important to remember is that we must investigate the underlying cause for the kernicterus, as in the second patient who has glucose 6-phosphate dehydrogenase deficiency. Chorea may also be seen in patients with vascular injury, as the girl in the video. You can, I don't know if you can see the MRI, but she has less putamen lesion, which is of vascular origin. This vascular chorea can be hemicorea or generalized chorea, and in most cases, when it's related to a vasculopathy, tends to remit. In the case of acute chorea, especially when there is association of encephalopathy, we must think of autoimmune encephalitis. Anti-MMDR encephalitis is the most common autoimmune encephalitis and represents the third most common cause of encephalitis, following viral encephalitis and acute demyelinating encephalomyelitis. This video is courtesy of Dr. Armangué. As you can see in the video, patient shows some degree. The first one has a lot of chorea. The second and the third one have a mild chorea. And this child usually present very acute and are very sick and are at the intensive care unit. Sorry. Now we arrive to the most common cause of chorea, which is the Sydenham chorea. Sydenham chorea is a delayed neurological manifestation of the infection with a group A beta-hemolytic streptococcus. In these cases, there is usually a history of pharyngitis a few weeks prior the onset of chorea, and brain MRI is usually normal. In most of the patients, there is a clinical resolution within the 2 years of onset. But also relapsing episodes are very frequent and are associated with new streptococcal infection or pregnancy. This is a case of Sydenham chorea. Chorea also is the most common movement disorder reported in patients with systemic lupus erythematosus, as you can see here in this patient. He presented a generalized chorea, and we will see the video of this patient after immunosuppressant treatment. This is a video after treatment. As you can see, all the correct movement has gone. Now we will comment on the genetic chorea. This is a very big group, but we will try to simplify by classifying patients into 3 subgroups. These 3 subgroups will be epileptic encephalopathy, inborn error of metabolism, and other chorea. Like that acquired chorea, in this case, we will start this part of the algorithm with the question of does the patient have associated epilepsy or abnormal video EEG? If so, we will include the patient into the group 1 and 3. If the patient has a red flag for metabolic disorder, we will see later which one are these red flags. We will include the patient into the inborn error of metabolism group. And if the patient neither has epilepsy, neither has a red flag for inborn error of metabolism, we will include it in the other chorea groups. Also, as we have said for acquired chorea, MRI is very useful and can provide additional clues for guiding the diagnosis. In the case of genetic chorea, there are neurological symptoms, including other movement disorders and also other extra neurological symptoms that can guide the diagnosis. These symptoms and their association appear in the final algorithm, but as you can see here in the in the screen, they are very long to explain, so I will not spend much time in this. I will just mention that, as you can see in the last slide, the skin examination and also the eye examination can give us very important clues to guide the diagnosis of a correct patient. Now we have a second question.
Yeah, so you should be able now to see the question and to vote.
I put this question here because usually what we know as benign hereditary chorea is one of the most frequent causes of genetic chorea. So it is very important to know that there is a laboratory testing clue to diagnose this patient.
Okay, 10 seconds to go. Okay, now I can show the results.
Well, yes, the majority of people vote for the correct answer, which is the hypothyroidism. That's the clue for the diagnosis of benign hereditary chorea. This is a list of some laboratory studies that can guide us to the diagnosis of the different chorea. You can see here that acanthocytosis is present in MBIA. The immunoglobulin deficiency is present, for example, in the ataxia telangiectasia. The increase of creatine kinase is present in the MEQ1, in the TRPC11, which are also some frequent cause of chorea. In the same way as acquired chorea, in genetic chorea, brain MRI can provide us many diagnostic clues for patients. Now we will see this with practical example, also with video, starting with the group of epileptic encephalopathy. This is a review work carried out by my group, Dr. Martinez Esteve and Dr. Bonino. They review or they study 2,200 patients published in the literature that carry one of the 77 omine genes for early onset epileptic encephalopathy. They found that 32% of these patients present a movement disorder and 16% of these patients presented choreatetosis. They developed a color map, as you can see here on the left, with the frequency of all the movement disorders distributed by the genes. This is also in preparation for publishing, and you will can access to this information very soon. Here in the blue box, we see chorea-associated genes that produce epileptic encephalopathy. Unfortunately, only 2 of them, the L13 and the PIGA, have a biomarker. All of the others don't have a biomarker, and the MRI is not quite useful, so we have to rely on the genetic testing. This is one of the most common epileptic encephalopathy with a movement disorder is the GNAO1 encephalopathy. This patient present very frequent dyskinetic crisis. They even have dystonic status. And this patient, it's very important to diagnose this patient because they can benefit from deep brain stimulation that prevent the status dystonico and that reduce the choreic form movement. As we can see later in this and other epileptic encephalopathy, besides the epilepsy or the altered video IEG, this patient usually have a severe hypotonia, as you can see here in the video. Sorry, I go back. This is a patient with a FOXG1 mutation. You can see here that this patient has a dysmorphic corpus callosum. This patient has frequent stereotypies and choreiform movement. They are also very hypotonic, as you can see here. The next one is a patient with a CAGNA1E mutation. This patient, besides the epilepsy, which is usually infantile spasm, they have macrocephaly and contractures. And they also have some dystonic posture. With also correct movement of the mouth. This is another patient with an epileptic encephalopathy. It's a green 1 patient. This patient has a severe developmental delay. They have severe intellectual disability. And they have this also correct movement of the hand that sometimes it's very difficult to differentiate from stereotypies. And also in this patient, in green 1 patient, we can find oculogyric crisis or abnormal movement, eye movement. Another question?
Here it is.
This question is to introduce our next subgroup of genetic chorea, which is the inborn error of metabolism.
Okay. Here are the results.
Very good. Also, the correct answer is the most voted is disorder of paroxysm. Usually this patient has ataxia or dystonic posture more than chorea. And chorea is assigned in all the other inborn error of metabolism. This is a review on a proposed diagnosis algorithm for the diagnosis of inborn error of metabolism that presented with movement disorders that is accepted and is going to be published in Frontiers in Pediatric Neurology. In this literature review, there were 231 inborn errors that presented with movement disorder. Usually, movement disorder in the context of metabolopathy are a combination of different movement disorders. Very few of them have only one or a characteristic movement disorder. And also, movement disorder is only a part of this neurological picture, because patients also have other signs like hepatomegaly, anemia, etc. Of note, there are only a few studies that make a comprehensive description of the movement disorder in the inborn errors. So in this work, I propose a 6-step algorithm for the diagnosis to guide the diagnosis of these children. As you can see here, choreoathetosis was present in the 13% of the metabolopathies that were described. This is the algorithm. I'm not going to comment on this algorithm, but I will on the red flags for the metabolopathies, because this is very important, and we have to have in mind, keep in mind all these red flags, because they are going to guide us to introduce the patient into this algorithm. We will think of metabolopathy when there is a, when there is a diffuse clinical picture with several neurological and non-neurological signs. There is a list of these signs in this article. Also, we will think of metabolopathy when there is a combination of different movement disorders, when this movement disorder presents acute or a subacute onset, or in the case of insidious onset, when the patient has a multiple previous non-systemic manifestation. Also, we will think of inborn error in patients with consanguinity, with a distinct neuroradiological finding, such as basal-ganglia abnormalities or hypomyelination of leukoencephalopathy or cerebral atrophy. We will also think of metabolopathy when there is an atypical or abnormal movement disorders that are not well explained by other classical etiology, such as the acquired causes or the other genetic causes. This is a list of inborn error presenting with chorea, and on the right side you can find the minimal biochemical investigation to diagnose a patient with chorea in the context of metabolopathy. Now we are going to see some examples of these inborn errors. In this case, we see another patient with glutaric aciduria. As you can see here, this patient has metabolic decompensation when he was 1 year of age due to a febrile illness. And now he presents a continuous choreodystonic movement, also in the tongue. As you can see, the darting tongue sign here. And this is a patient with glutaric aciduria. Glutaric aciduria is one of the most common causes of chorea in patients with metabolopathies. This is another patient with a more insidious picture. This is a patient with a mitochondrial disorder with an AEFM1 mutation. As you can see here, this patient is very hypotonic. He cannot sit by himself, and he has this continuous movement. On the MRI, he has a dysmorphic corpus callosum. He did not have olfactory bulb. and he has leukoencephalopathy. This is another case of chorea in the context of metabolopathy. Here we see a patient with Lee syndrome. You can see here that this patient presents mild choreic movement, not only in the upper extremity, but also in the lower extremity. On the MRI on the left, you can see that she has hyperintensity of thalamus. She also has hyperintensity of the brainstem. And these were the cases for the inborn errors and chorea. Now we will talk about other chorea. And in the other chorea group, we include all the other chorea that are not epileptic encephalopathy or inborn errors. The most common causes of chorea appear here in the blue box on the lower left. This patient on the video has benign hereditary chorea or due to a NKX2-1 mutation. As you can see here, this patient usually have a childhood onset chorea before the age of 1 year, but it can appear later. They also have frequently have neonatal respiratory distress, and nearly a half of these patients also have hypothyroidism, and that's a diagnostic clue for this patient. Here in the video is another patient with chorea due to NKX2-1 mutation. As you can see here, she has a generalized chorea, including both upper and lower limbs. Some of these patients also can have dystonic posturing or myoclonus. It's not just chorea. Another frequent cause of chorea is the ADCY5 mutation, as you can see here in the video, in the upper. This patient has a generalized chorea. They can also have dystonia or myoclonus. They are usually very hypotonic with a poor head control, as you can see here in the video. The MRI usually is normal. They drop their head when they are young. That's a very good sign also for the diagnosis of this patient. This patient also has nocturnal spell that is not present in other causes of chorea. That's also a very good diagnostic clue. In the video, in the upper zone, you can see a patient with a nocturnal spell. In the video, in the second video, you can see the patient with some chorea and some dystonic posturing. They have a lot of problem with gait. They usually have delay gait and also frequent falls. Another cause that we have to have in mind with chorea, with genetic chorea, are the phosphodiesterase, both the 10A and the 2A. As you can see here, this is a phosphodiesterase 10A chorea. This patient has, along with the chorea, he's very hypotonic. He cannot hold his head, and he has all this movement. Chorea in the phosphodiesterase 10A can be autosomal dominant or recessive. There is a difference in the onset of chorea between both phenotypes. Also, there is a difference in the MRI. This is the MRI for the autosomal dominant form. As you can see here, there is an hyperintensity of the caudate and the putamen, which is not seen in the recessive form. Another cause of chorea, although these are very rare patients, is the phosphodiesterase 2A. This was the first patient diagnosed with this genetic defect. I know that there are some cases also in France. And patients with this phosphodiesterase deficiency have not only chronic chorea or chorea, generalized chorea, but also they have dyskinetic or paroxysmal dyskinesia, and also this dystonic posturing on the lower limb. They also have a mild intellectual disability. And this patient underwent to DBS. The DBS improved the chorea to some degree, but he's still having this correct movement. This is another patient from literature. Here you can see a very severe patient, very severe developmental delay. This patient has this correct movement. This patient also has optic atrophy. And this is due to the ATPA2 mutation. This is not a very common cause of chorea. This was a very interesting case because this patient has congenital nephrotic syndrome, the Finnish type. And in this patient, in some of these patients, it was described that they have chorea, as you can see here in this patient. She presents this choreatetotic movement in the hand. The MRI in this case is normal. And this is another case from literature. This is a 2-year-old girl who presented this dystonic and correct movement that improved with levodopa. And she was found to be affected by ataxia telangiectasia. This can be one of the forms of onset in this disease. That's why it's very important to include the alpha fetoprotein in the laboratory investigation in a patient with chorea. Now we will comment on other rare causes and unsolved causes of chorea. Juvenile Huntington disease can present more frequently with a dystonia Parkinsonism phenotype rather than a choric phenotype in patients younger than 20 years of age. As you can see here in this patient, he has this abnormal gait. He has difficulty in tapping with the finger. He also has some dystonic posturing on the face when he protrudes his tongue. And the MRI in these cases is very characteristic because there is an atrophy of the caudate and putamen along with hyperintensity. And also in this case, there is a past webinar on the ERN webpage where Dr. Esquitieri talks about the juvenile Huntington disease. And not to forget that, as we say before, even though we've done all we can for diagnose this patient, we will have some unsolved chorea patients This patient can be included in the SOLVE initiative for a specific cohort or of rare disorder. Chorea is one of these disorders, and you can contact to the project to include your patient. As conclusion, we'll say that chorea in children has a wide variety of etiology, including acquired and genetic causes. The type of onset and the age of onset will allow us to differentiate between genetic and acquired chorea. MRI is essential in the study of a patient with chorea. You can find this algorithm in the ERN webpage. And also, it is important to identify the cause in order to provide a good treatment and for the patient to have a good prognosis. Thank you to all the patients and the families, and thank you to you all.
Thank you, Dario, for this very insightful webinar and very instructive. So we can go to the questions and answers. There, I see there are already 4. This was some. Okay, so one question is CBZ drug usually efficient to treat choreic movement disorders in children?
Yes, the literature says that carbamazepine, valproic acid, or prednisone can be used to treat patients with side and hand chorea. In the case of other choreic movement disorder, we can use tetrabenazine, and we can also use risperidone to treat this patient. And in some genetic cases, there is an indication for deep brain stimulation.
Thank you. So many of the attendees are already saying thank you for this webinar. Another question from Anna. Do you do a trial with levodopa in all children presenting with choreiform syndrome?
It depends on the case because, levodopa sometimes can increase the choreiform movement. So we have to be very careful and only indicate this treatment when there is a clear dystonic posture. So levodopa, more than a choreic indicated for choreic movement, it will be indicated for dystonic for dystonia.
Thank you. Another question, is there chorea in STXBP1 epilepsy in children?
Yes, some patients can have chorea, but in syntax in patient, stereotypy, ataxia, and dystonia, and also tremor are more common than chorea. But yes, some patients can have chorea too.
How do you feel about the use of tetrabenazine in rheumatic chorea?
I will not indicate it because I think that, for example, carbamazepine or valproic acid has less side effects than tetrabenazine. So I will prefer to use carbamazepine over tetrabenazine for this indication.
Okay, thank you. What is the first line drug of chorea?
It depends on the cause. Because, for example, if in side and hand chorea, I will say carbamazepine. In the United States, I know that they use prednisone rather than carbamazepine. But it depends on the case of the patient. Tetrabenazine and risperidone also are very effective in for the treatment, but we have to be aware that there are some causes of chorea that will only improve. They only have a mild or moderate improve, and we are not going to cure the child with the correct movement.
Mm-hmm. Okay, another question from Bernhard Landwehrmeyer. He says, great presentation, congratulations. And the question is concerning pediatric onset chorea due to dominant PDE mutations. Is this a dominant loss of function?
It is a loss. It is a dominant loss of function. They calculated in the first report that the PDE-10A only has a 70% of activity in a mouse to cause the chorea.
Mm-hmm. Okay, so many people have praised your presentation, Dario, and congratulating and saying thank you for this wonderful presentation. We may wait for 1 minute more if there is somebody still who wants to ask his or her question, and otherwise we will close the webinar. In the meantime, I would like to tell you that next week on Tuesday, again, the same time, there will be another webinar on clinical practice recommendations for physical therapy for Huntington's disease by Bernhard Landwehrmeyer. So stay tuned. It is again a topic in the same disease group. And yeah, so yes, here it is, one more. Role of steroids in rheumatic chorea. What would you say about that?
Yes, some especially in the United States, they use prednisone as the first line treatment for rheumatic chorea. So it is, yes, it can be used. But, with here in Europe or especially in Spain, we have a good result with carbamazepine. So we prefer to use this rather than prednisone.
Mm-hmm. Thank you. Another question, what kind of models or experiments are mostly used in chorea research? Do mouse models even suffice to see the symptoms? Do you know of cell models too?
Yes, for example, in GNA01, the GNAU mutation, there is a mouse model. I know that they are using mouse model and that the mouse has a hyperkinetic phenotype that resembles chorea and have been used for experiments. I don't know of any other cell models, but I guess they are probably zebrafish and models for chorea too.
Mm-hmm. Thank you. And another one from Bernhard. Are there long-term cognitive or behavioral abnormalities in Sydenham's chorea?
We know that there are short-term cognitive and behavioral abnormality, but I think that the long-term cognitive and behavioral abnormality have not been explored in a very good way. It will be very interesting to conduct a study to know about that.
Mm-hmm. And I would propose we take the last question, which is there a transgenic mouse model of BHC displaying a choreatic phenotype?
I really am not aware about this transgenic mouse model. I think I will have to find out if there is. I don't have an answer for that question.
Okay. So there were many questions. This was a nice interaction with the participants who we don't see, but we know like this that they are there and they are interested in the topic. So thank you very much, everybody. Stay safe and see you next week on Tuesday. Thank you, Dario.
Thank you very much to all.
Bye-bye.
Bye.